The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everybody. I'm Michael Flora with MTM Services. It's my pleasure to be with you today as we look at our collaborative documentation as a staff self-care tool. I'm sure everybody can see the screen now, so you're able to take a look at that. Let's go ahead and jump right in. A couple things we think about with the core competencies in the new value-based workforce shortage environment that we're all in. We think about access and intake and consumer scheduling, information and medical records management, workforce engagement and human resource management, billing and financial and cost containment, strategic and business planning and financial viability, safety and risk management, continued quality improvement and compliance, outreach and awareness, and governance and leadership. All of this centered around outcomes. Can we demonstrate that we're meeting these expectations and core competencies in the new environment? And you can see I've highlighted three specific here that I believe that collaborative documentation helps. So first is workforce engagement and human resource management, safety and risk management, and continued quality improvement. And so this is going to be primarily the emphasis that we're seeing as part of our work today around the core competencies in the new environment. Let's break this down by the numbers. The vast majority of the nation's behavioral health workforce currently believes that without public policy changes, provider organizations won't be able to meet the demand for community behavioral health care services. And this is according to the National Council for Mental Well-Being in their April 2023 report on the state of the organizations. And around 9 in 10 behavioral health workers are concerned about the ability of those to not currently receiving care to gain access. Nearly 2 in 3 staff members reported increased client caseloads, and more than 7 in 10, 72%, reported an increase in client severity. Four in 5 say their passion for working in the industry is unwavering. They're committed to do this work. And more than 9 in 10, 93%, said they have experienced burnout. And the majority report suffering from moderate or severe levels of burnout, 62%. Nearly half, 48% of the workers, say that the impacts of the workforce shortage have caused them to consider other employment options. And we're definitely seeing that with folks moving to other industries. And more than 4 in 5 behavioral health care workers, 83%, worry that the workforce shortages in our community mental health system will negatively impact society as a whole. And a third of the workforce reported spending most of their time on administrative tasks. 68% of those provided care to patients, saying that the amount of time they spend in administrative tasks takes away time they could spend with their clients on their caseload. And so that's where we see collaborative documentation as a great option for team members to decrease the administrative burden. So again, that administrative burden takes time away from their tasks. Additionally, 38% less time spent on administrative tasks would allow them to serve their clients better. So that the burnout factor, the administrative tasks. In fact, 37% say that their negative impact on their work-life balance, their own emotional health and well-being, and the impacts of workforce shortages have caused them to consider other employment. So even SAMHSA has said that we're going to continue to see the workforce shortage continue. 98% shortage in peer support, 97% shortage in addiction psychiatry. And so SAMHSA is even saying that the workforce shortage, there's no sign of easing. By 2025, we'll be short another 31,000 full-time equivalent mental health and substance use practitioners. So how do we create those workforce solutions? Well, first we have to streamline our documentation requirements. Many of the exit interviews that I've reviewed over the past several years, the administrative burden, the amount of documentation our team members are completing is driving them to look for other employment. So we must eliminate our redundant processes and implement collaborative documentation. See, the problem motivating our teams and remote team members to peak performance is not a lack of reinforcement. When we don't get enough reinforcement for what we're doing, our attention wanders, and therefore so does our performance. So the amount of reinforcement needed to keep people focused on their work is relative to the amount of reinforcement available in the environment. So think about what keeps your team members distracted, especially when we think about documentation. So access to the Wi-Fi, accessibility and availability of the resources in the community and in the office, emails, team Zoom meetings. Our teams are in back-to-back all day, and so they don't have time to do their documentation. So how can we streamline that for them? Well, the first is actually just making them part of the actual session. So depending on the organizational culture, the fewer distractions in the workplace, it takes very little reinforcement to keep people on task and help them be successful. If there's a lot of distractions, it takes a lot to keep people focused and motivated for what they do. So let's talk about collaborative documentation as an individual and family engagement tool, but also a staff self-care and retention tool. How can we help streamline the documentation, make it easy for our teams? Does this look familiar to anybody? Where our team members are buried behind mounds of documentation and paperwork? See, the goal of collaborative documentation is this no longer looks familiar to anyone. In fact, we hear testimonials all across the country of teams that we've trained in collaborative documentation that they go home for the first time in, let's say, 20 years, that they've been able to get their actual work done. So collaborative documentation is a process in which the clinician and the individual served collaborate in the documentation of the assessment, the service plan, and the progress notes. It's a clinical tool that provides clients the opportunity to provide their input and perspective on their progress and allows the individuals and their clinicians to clarify their understandings of important issues and outcomes. They're present and engaged in the process. So let's think about this. How much time do you or your team members spend in documenting clinical services after the consumer has left your office, after we've logged off that Zoom call? How many times are your staff members logging in from home to complete their needed documentation? Let's take a look at this. On average, what we find is the average clinician spends about 10 hours a week in post-session documentation. So let's break this down a little bit. So if I have one team member, that's 10 hours a week with 48 billable weeks a year, allowing for vacation, holiday, and sick. That's 480 hours a year. Let's just say that we were able to convert that to direct service as opposed to blocked documentation time. With an average, let's say, reimbursement rate of $85, that clinician for that 480 hours could generate another $40,800. that we could definitely give them part of as part of a raise, merit increase. But let's take longer for this. Let's take 100 staff members at 10 hours a week. That's 1,000 hours a week. Times 48 weeks, that's 48,000 hours of documentation time in post-session. Now, whether this time is on their own time or company time is a different issue. But let's say it's on company time, then that would be another $4 million. So what do you want to do with another $40,800 per clinician? What do you want to do with another $4 million in your organization? Now, in a value-based or capitated environment, that might be $4 million of opportunity, or in essence, maybe just cost that we're spending, that we can convert to reality of what we're doing. But take a look at this. That 480 hours a year is 60 calendar days a year of staff documentation. Let that sink in a little bit. So our team members are out of pocket per FTE, if they're spending about 10 hours a week in post-session, 60 calendar days doing nothing but documentation. No wonder they're tired, burned out. By moving to in-session documentation with collaborative documentation as opposed to post-session, staff are going to spend around 6 to 8 hours. So that 10 hours a week in post-session documentation is going to be reduced at least by 6 to 8. Because when we talk about collaborative documentation, remember, it's a tool, not a rule. The rule is I got to meet my documentation timeliness expectation. Collaborative documentation is definitely a way to help get you there. But there are going to be those times where it may not be clinically appropriate to complete collaborative documentation, and that's okay. That's why we give a little wiggle room there on that 2 hours, let's say a week of post-session, that definitely could be used to either blocked in my schedule so I'm not doing it after hours, logging in, staying in late. So in a nutshell, collaborative documentation improves engagement of the individual served. It helps support clinicians and saves them valuable time. And for the organization, it provides improved documentation accuracy and corporate compliance. So we have to think about how this is appropriate for all populations. And what we found over the years is that this is appropriate for all populations: children, community-based, group. All of the populations that we work with, collaborative documentation can be a valuable component. It's not documenting every single word the individual says. We're not court stenographers. We're not typing every single thing. We're not writing a novel. Collaborative documentation reinforces the concept of nothing about me without me. We also have found that by moving to collaborative documentation, individuals and organizations see about a 10% increase in client show rates after implementation. Why would we see an increase in show rates, or a 10% increase in show rates, or a decrease in no-shows and cancels? Because individuals see the value. We're having that discussion with them at the end of the service encounter to find out what was helpful today. What's the plan for next week? See, collaborative documentation is a process in which the clinicians and the client collaborate in the documentation of the assessment, the service plan, the progress note. It's a clinical tool that provides clients the opportunity to provide their input and perspective on services and progress, and allows clients, the clinicians, to clarify their understanding. As we said, collaborative documentation is a tool, not a rule. The rule is I've got to get my note done, my assessment done by the close of business today. With most organizations moving to same-day close of business documentation. Other organizations are moving within at least 24 hours of documentation. We don't necessarily recommend note completion expectations past 24 hours, and we'll talk about that in a little bit. But also that collaborative documentation is a staff self-care tool and is part of the clinical intervention itself. Actually using the document as part of the intervention, as a tool in session, whether it's in the community, a group, a case management, community-based work, individual psychotherapy, med management, adults, children, birth to 5. And it promotes client engagement in treatment. Simply, it's just a model of documenting the session content with the individual or family present at the same time at the end of the service encounter. We're going to take the last few moments of our time together. We're getting close to the end of our time today, Michael. Let's stop here and document the important work that you've done today. Remember, we're being succinct in writing that note. Moving away from clinical jargon and terminology, which we have understood to negatively impact treatment, moving to more client-centered, recovery-focused language, using terms and phrases that the individual can understand and relate to. Now, it's perfectly acceptable to use clinical jargon in our sessions together if the individual understands the clinical jargon and terminology. Have we used that as an opportunity for education? What does rapid and pressured speech mean? What does a flat affect mean? Giving the individual the opportunity to give their feedback and perspectives. See, instead of just writing down my notes on a yellow legal pad or a post-it note trying to remember what went with who, I'm doing it in session with the individual or family present at the same time. Because it demonstrates value in what we do. So just a brief tutorial on the value of care equation. We have customer service, which is the ability of all team members to be engaged, to meet and exceed the internal and external customer service expectations, and improving that customer service experience of care to achieve better outcomes at a lower possible cost. So what better way to engage our individuals and provide great customer service than having a discussion at the end of the encounter to see what questions they may have? Is there any work or homework you would like me to work on between this week and next week? Am I going to practice a coping skill we worked on today? I'm going to be identifying a trigger. Am I keeping my diary card? Collaborative documentation also allows us to open up time in our schedules to meet the current caseload and defining the evidence-based practices that we're working on with the individual. The cost of services provided in the current healthcare environment. So what does it really cost us by CPT, HCPCS, and provider type? So remember when I shared that $40,000 per clinician? Right now, that could be $40,000 of cost to your organization, as opposed to maybe $40,000 worth of revenue that we could provide increased compensation and supports that might be needed for our staff. Outcomes achieved. If I'm focusing on the outcomes, the progress that the individual's making in session, then every session we're checking in, giving almost to that level of feedback. Is what we're working on today achieving our goals? What progress are we making? Remember that quality is determined if we can achieve the same or better outcome with a change in service process cost, with a change in service delivery that makes the value in the new model a better value for the payer and ultimately the individual served. So what is collaborative documentation? Well, it's where the individual and the clinician are engaged in completing the documentation together. So whether this is an individual session, a skill building, case manager, even group, it changes our perspective from documenting about you to documenting with you. So again, nothing about me without me. It promotes client-centered care. It engages and motivates the individual, supports shared decision-making between the clinician and the individual served, and utilized as a tool to engage the individual in treatment. So we think about doing this in individual, we usually, a good progress note should take about 7 to 10 minutes in session with the individual present. It's a summary, it's a synthesis of what we just did for the last 40, 45 minutes. What goal did we work on today? What intervention and evidence-based practice did we provide? What is the individual's response to that intervention? Did they feel they could do that intervention in the community? Did they find it was helpful? What progress does the individual feel they're making in our work together? And what's the plan for next week? Now, we might be familiar with a DAP note or a SOAP note. We call that a GURP note, the goal, the intervention, the response, progress plan. And allowing our clinicians to really focus in on those specific areas, because every note we write should be standing alone, correct? So being able to go back on that note and say, what goal did I work on today? What intervention did we provide? What is the individual's response to that intervention? What progress, outcomes are we making? What's the plan for next week? So when you think about it's not documenting every single word the individual says. Now, there's some parts of this, like the assessment and perhaps the treatment plan, that are going to be done what I'm going to call in our training when we work with teams nationally. We actually break this down on and how to really look at how to do this in the assessment, which I'm going to call both concurrent and collaborative. So I'm going to ask you a series of questions during our assessment. There's a lot of information to gather, but we'll do it together to make sure that what I write accurately reflects the information you're providing. I'm going to ask you a series of questions. I'm going to type your responses as part of that assessment, and I'm going to read back to you what you said, and you can help clarify my understanding, and then we'll move on to the next section. What many clinicians do here is just provide the individual served or the family with an outline of the assessment. Not necessarily all the questions, but at least a topic area. Family history, presenting issues, current symptoms or behaviors, and just an outline. That way they know that the assessment and what the purpose of the assessment is to really use to match you with one of our caring professionals here at our organization. And then what the next steps are in that. Think about when you go to primary care and they document in the exam room, as we know, in exam room documentation, or really any type of in-session documentation, whether it's collaborative or primary care's open notes version, collaborative documentation can be done well or can be done poorly. It's really up to the clinician. And think about that shared decision making, that you and the individual served have a clear understanding of what we're doing. And remember that we're not billing for documentation. That question just came up in the chat. It's still the session. It's not like, let's stop the session and do our note. It's part of the intervention. It's a summary, it's a synthesis, so it's not a start and stop. So I'm going to do 40 minutes of therapy and 10 minutes of documentation. We can't bill for documentation. And many states have even come out with some clarification around that. I know Pennsylvania has done that, Virginia has done that, and even in California with the new CalAIM initiatives. So we're incorporating that active discussion as part of our work together. It encourages and motivates the individual served. See, it allows the individual and provider to really focus in a very proactive manner and confirm the goals and objectives of today's session, the therapeutic interventions provided by the direct care staff, and their feedback regarding the progress, indication of their perceived benefit. In addition, this practice is an appropriate extension of that therapeutic intervention, which serves to focus the client and the family on what just occurred in the session and what their next steps will be. In fact, when we think about what's happening now all across the country, collaborative documentation supports the 21st Century Cures Act. See, the 21st Century Cures Act was put into law in 2016 and then reinforced again in April of 2020. The rule is designed to give patients and their healthcare providers secure access to their health information through a patient portal. It also aims to increase innovation and competition by fostering an ecosystem and new applications to provide patients with more choices in their healthcare. It calls on the healthcare industry to adopt standardized application programming interfaces, which will help allow individuals to secure and easily access their record. So think much like primary care, where you can go in and review your exam note. I know when I go to my primary care physician, he's documenting in the exam room with me present, reading back to me what his observations or next steps are, his conclusions, and do I agree, getting my input on my shared decision around my health care, going over my lab results. And then by the time my foot hits the curb, I get a ping on my cell phone that my patient portal has been updated and I can review my note for today. Why do you think that might be important for the individuals we serve? A study previously noted that well over 60% of individuals seeking healthcare leave their provider's office confused about what to do next. So you add in the complexities of comorbid behavioral healthcare needs on top of perhaps primary healthcare needs. That increases the likelihood of confusion, what I'm going to call those homegoing instructions. So let's talk about some of the clinical benefits of collaborative documentation. Well, it provides the individual served the opportunity to provide their input and perspective on services and progress. It supports providers and the individuals with, including the family, especially with younger children, the opportunity to continuously review treatment needs, obstacles, goals, and progress. And it supports increased engagement and involvement around our treatment outcomes. What specific goals and objectives are we working on? See, collaborative documentation keeps documentation in real time. The accuracy of the documentation increases when we're not trying to recall the interaction. And care coordination and risk management. So think about those two right there in the middle. I was working with a team recently on their notes, and they have notes outstanding from last November. Think about that for a moment. What did you do last November 3rd? What did you have for lunch last November 3rd? What did you have for lunch last Tuesday? See, but I don't have to recall what I did. That increases the likelihood that that note is going to meet compliance documentation expectations. It helps with care coordination and risk management. Let's say that you see me today and I barely got on the Zoom call to see you because of increased depressive symptoms. Now I can document that in real time, and the prescriber knows about that tomorrow when they see me, or other individuals, because this is about also team-based care. And supports that timely communication with other providers. I also think, not only is it true informed consent, but, our individuals sign releases of information. They sign consents, they sign HIPAA, but they really know what's in their chart? Do they really know what's being released to probation, parole, children protective services, the school nurse, the primary care physician? It helps the individual because it allows them in the therapeutic process and recording their session content to review their feedback and description and insight. I remember I was doing a training, and the supervisor was working with their individual right after the training that we did at their location. And at the end of the session, they were doing their note together. What was interesting is that the individual served and the clinician had two different perspectives of the client's response to the session today. And they were off a little bit, but allowed them an opportunity to have that discussion at the end to say where the difference may be. And what the supervisor said from then on, the client said, well, Nick, it's time for us to do our note now together. So the client wanted to really make sure. And we definitely see that across the country where our individuals served really like this. And I'll show you some data on that. It empowers the individual to determine the course of their clinical assessment and interventions and progress in therapy. That real-time feedback increases their buy-in and outcomes. And cutting out that out-of-session time results in increased hours for the clinician to actually see folks on their current caseload, which is going back to some of the data from the National Council's survey on employee workforce needs, is that they want to be able to see folks. They still have a passion for this work, but somewhere the documentation has become the enemy. There's benefits of collaborative documentation for our team members because it allows the clinician to clarify their impressions and therapeutic interventions by putting them into words in front of the consumer. It ensures greater content accuracy because I don't have to remember what I did 2 weeks ago. It gets me as the clinician off the treadmill of all the documentation requirements. I'm going to save my 8 hours plus a week in post-session documentation. And if I'm doing that on my own time, that's 8 hours of my life I get back. If I'm doing it on your time, that's 8 hours that I can maybe follow up with my clients. I can make phone calls. I can prep for my next sessions. I can get people in that are on my active caseload. See, with increased time availability, this allows clinicians to be less anxious about accepting and seeing more consumers on their caseload. By converting to collaborative documentation, here's an interesting fun fact. We see a 25% reduction in staff sick time, because I don't have to call in sick to get caught up on my notes or call in sick because I'm burned out. I'm actually using my PTO and my sick leave for the appropriate reasons. Less anxiety and less stress for direct care staff results in enhanced morale and greater job satisfaction and improved quality of life, that sense of well-being that we're all striving for. So there's benefits to the individual served, there's benefits to the organization, and there's benefits to our team member. And collaborative documentation is for all programs, all services, all age groups. It helps the agency because it sets that standard for clinical formulation to ensure that all documentation is consistent and compliant with agency applicable state, federal, and accreditation guidelines. Increased documentation compliance lowers the likelihood of payback via audits. Staff increased availability helps see clients on their caseload, increased morale, quality of life, reduces turnover and burnout. I saw that at my clinic. Before we implemented collaborative documentation along with other major transformational initiatives like same-day access, no-show management, centralized scheduling, we had about a 40% staff turnover rate. When we implemented these transformational changes to really support our team of professionals, staff turnover dropped to 3% the first year because staff reported they were able to go home at the end of the day with their work done. They have that sense of attainment, not feeling behind all the time. But sometimes we hear some common concerns nationally. Perhaps you've heard this from your team. It's not fair to clients that resent doing paperwork. Well, remember, we're not doing paperwork. We're writing a summary of the work we've done today. So we're getting close to the end of our session today, Jody. Let's stop here and document the important work that you've done today, as opposed to, Jody, you sit there while I do my note, my paperwork. We're engaging them. That's an active discussion at the end of the treatment encounter. It'll interfere with the client-therapist relationship. We actually see it enhances the therapeutic relationship. It takes time away from treatment. Remember, it is treatment. It's that summary, the synthesis of what we just did. We're gaining insight and understanding of the individual. What happens when your team member says, well, I need the time to think about what I write before I complete my note? That's a training issue. Many of the notes that I've read over the years, there's too much information. There's too much in there that's not relevant to the intervention or services that we provide. We're filling in the blank. We're filling in the space. See, we were taught to document how smart we are. We were taught to document 75-cent words and clinical jargon. Now, back in the day when I went to graduate school, we didn't talk about collaborative documentation, but I did collaborative documentation, but not knowing what it was called at the time. See, the course I took in graduate school was called defensive documentation. We were taught to document that as if everything went to court. We were taught to document deficit-based language because we were taught in a medical model, which is all about symptoms and disease. And so we're shifting. A lot of the training I do now with teams is we really move towards client first, recovery first language. So let's help that clinician who's writing a lot or needs time to think about it. Because a couple things to think about when you're actually doing the notice, you can write in bullets in your progress note. Because what I want to be able to do is capture the goals, the intervention, the response, progress plan. I can go back and clean up sentence structure and spelling, as long as I'm not changing content. Remember, nothing about me without me. And it's a skill set, obviously. It's a mental muscle that we're helping our clinicians and support. So much of the work that we also do is not only the training with the clinicians and our direct service professionals, our peers, our residential team members, but also managers, supervisors in training. The training we provides not only collaborative documentation training, the core clinical training, but also train the trainer. So you can help support your team in this work. You cannot complete collaborative documentation during a crisis situation. Maybe not, depends on the crisis. If you're working with me to community stabilize, working with my local resources to deflect an inpatient care, then obviously we want to document that crisis plan, that safety plan. But if I'm agitated or it's not clinically appropriate, then don't do it. Which moves us to what I call the 7% rule. See, we should be doing collaborative documentation about 93% of the time, which gives us 7% that it may not be clinically appropriate, and that's okay. Do as much as you can or as much as the individual can tolerate. But also part of our work that we do with teams nationally is we look at individual and staff satisfaction surveys. So let's take a look at a little bit of this data. On a scale of 1 to 5, how helpful was it to have your provider review your note with you at the end of session? 52% said very helpful, 31% said helpful. On a scale of 1 to 5, how involved did you feel in your care compared to past experiences with this or other agencies? 53% said very involved, 24% said involved. On a scale of 1 to 5, how well do you think your provider did in introducing this new system? 70% said very good, 24% said good. On a scale of 1 to 3, in the future, would you want your provider to review your note with you at the end of session? 77% said yes. Here's a couple staff satisfaction questions. On a scale of 1 to 5, how involved are your clients in the treatment process as a result of collaborative documentation? 14% said very helpful, 38% said helpful, 38% said about the same. On a scale of 1 to 5, how helpful has collaborative documentation been in your paperwork proficiency? 46% said very helpful, 39% said helpful. But remember, collaborative documentation is part of the clinical intervention. Now, back in 2013, we did a 10-center study across the country where we looked at medication and treatment adherence as a result of collaborative documentation. So in our study that was published in Psychiatric Services in 2013, the impact of person-centered planning on collaborative documentation and the treatment adherence, what we found was that we had two groups of individuals. We had subset A and subset B. Subset A clients were the clients that received collaborative documentation. Subset B individuals were the ones that did not receive collaborative documentation. What we found is that the individuals served reported greater medication and treatment adherence as a result of the utilization of collaborative documentation. There's positive outcomes, there's positive engagement. And we also asked their providers. As a result of doing collaborative documentation, remember that the subset A clinicians were the ones that were trained and implemented collaborative documentation into their practice. We asked them, do you feel that your individuals served were more engaged in the process, more treatment and medication adherence? And they said yes. But see, collaborative documentation has been part of larger healthcare for years. And a Robert Wood Johnson Foundation funded in 2012 that looked at 19,000 individuals at 3 health centers across the country. They used a concept called Open Notes, which is basically primary care's version of collaborative documentation. The study revealed that patients who participated in Open Notes felt more in control of their health care, experienced improved recall of their care plan, and reported they're more likely to take their medications as prescribed. Doctors' fears about the added time burden or offending or worrying patients did not materialize. And many doctors report that note sharing strengthened their relationships with patients, including enhancing trust, transparency, communication, and shared decision-making. In fact, Robert DiCarlo, in his 2017 doctoral thesis, Collaborative Documentation in Community Behavioral Health, the Impact of Shared Record Keeping on Therapeutic Alliance, reported the practice appeared to improve trust through increased transparency and created a platform for providing feedback to clients that prompted insights into behaviors and cognitions more quickly than before. Ultimately, the therapist's comfort level and skills appeared to influence the adoption of collaborative documentation. I'll take it a little bit further. If the supervisor or manager isn't bought into collaborative documentation, their team members that they supervise will not be bought into collaborative. If the clinician is not bought into collaborative, then their individuals served may not be bought into collaborative. So collaborative documentation is just that accurate representation of what went on in session with the individual. As we said earlier, as time passes, the documentation becomes more vague, homogeneous, and less helpful. So we talk about how to move from post-session documentation to in-session documentation. We talk about this collaborative documentation in real life. So one of the things we think about is office setup. Do your team members have the equipment they need? So one of the first things we do with teams is to really look at an equipment and information technology assessment. Do your staff have monitors so you can see the various aspects of where collaborative documentation can be done? In the office, telehealth, in the community, in schools, via cell phone. In fact, many peer recovery support specialists and community-based staff report that using the talk-to-text feature on their cell phone and sending themselves an encrypted voicemail or encrypted email has been very helpful to do documentation in the field. Other clinicians have reported having laptops or tablets or toughbooks in the field helps them. But also that requires us to really think about technology and adaptive technology in the community. Is it Dragon? Is it talk-to-text? But also, do the clinicians have the monitors? In office-based setups, we do recommend dual monitors because part of this is, can the client actually see the screen? We want the individual to see our screen. So I'm going to move up. I'm going to have either a second monitor for them to look at, or I'm going to share my screen with them. Now, the only difference between group collaborative documentation and individual collaborative documentation is that in individual collaborative documentation, we're sharing the note, the document, the assessment, the treatment plan, the court report with the individual in real time as we're working on it together. We're collaborating on completing the documentation together. In group, it may not be clinically appropriate that I'm going to pull up all 7 members of the group's progress notes. But what I can do is complete the master group note. Everyone in group today received the exact same intervention. So for curriculum-based groups, we can pre-populate the intervention ahead of time. This is stages of change 7 of 6 or 6 of 7. This is DBT number 4. Then I can go in and say, take 2 minutes per person at the end of group, much the same way that we do our normal group checkout. So Mary, what did you get out of group today? Scott, what did you get out of group today? David, what did you get out of group today? Or Kyle, what did you get out of group today? Then I'm going to just spend a few moments documenting that and actually giving them a document that says, what did you get out of group today? What did you find helpful today in group? How will you use today's group in your ongoing recovery? So what we found over the years is that by moving to collaborative documentation, not only does it improve individual served engagement and participation in treatment, it increases documentation timeliness, but also it's a staff self-care tool. I get to go home at the end of the day with my work done. It allows me to take time that perhaps I was spending in documentation during regular work hours to make those phone calls, to follow up, to provide that care coordination, prep for my next session. I can go back in and clean up the note. I can go back in and clean things up as long as I'm not changing content. So again, it's nothing about me without me. All right, so let's go through some of the questions in the chat, but also if you want to, feel free to add those questions in the chat. So yes, you'll be sent copies of the PowerPoints as you registered for this webinar. And so when we talk about, so Karina wants to know regarding specific populations, this may not be feasible. It's not so much about which populations or perhaps which situations today. So we want to be able to do collaborative documentation about 93% of the time, which gives me what I call that 7% rule, where the clinicians would use their best clinical judgment. Is today the day it's going to work with Bob? So today it didn't work with Bob because Bob's really agitated, he's upset. So it may not be appropriate today, but it doesn't mean it's not going to work with Bob next time I see Bob, or the Jones family next time I see the Jones family. So it's in the community, with children, even in that Birth to 5 or CPP program, because we're providing that synthesis, that working with the family or the caregiver, giving them the support they need to work with the child in that situation. I found by doing documentation with individuals that they get a very clear understanding. But I think one of the common fears among many clinicians is that, what if their opinion is different than the individual served? That's fine, then just document both. If you feel I'm making progress and the individual served feels that I'm not, then that's fine. Just document both perspectives. You're entitled to your clinical opinion and observation. Just put it in words in front of me, so there's no surprises. See, I think with the Cures Act, what would happen right now if the individuals that you work with went into the electronic health record and read what you wrote about me? Would they be okay with it? See, I'm reminded, I did a training in Virginia several years ago, and one of the things that impressed me the most about that is that there was a peer recovery support specialist that stood up and read an open letter to the clinicians I was training that morning. And in his letter, he said, you know what, I always thought I had a great working relationship with my therapist, my prescriber, my case manager, until I read what you wrote about me. I was malodorous. I was unkempt. I was unmotivated. I lacked insight. I was paranoid. I was delusional. And what he said was powerful. He said, these were words that you never, ever said to me to my face. You didn't tell me I was malodorous, that I was paranoid, that I was delusional. They said, in reading my note, it made me rethink who I was as a person, which is really why, team, we emphasize moving to person-centered language. There's a lot of research out there in person-centeredness. And in fact, NYU University is currently undergoing a study that we've had one of our teams participate in, where they're looking, it was actually some preliminary results were published in Social Work Today a few months ago, on really looking at person-centered language in collaborative documentation. And one of the things that NYU did and at Fordham University are doing in this research study that we publish soon is they went through and looked at a numerous amount of notes from a team that we trained in Iowa. And they looked at notes pre-collaborative documentation and post-collaborative documentation. And what they found, preliminary results are showing that we're seeing an improvement in person-centered language because I'm putting my documentation in words with you present. See, the Cures Act requires all healthcare to allow individual access through a patient portal. I can review my labs, my bill, my documentation, my assessment, my progress notes, my psych eval, my med list. So moving away from documenting about you to documenting with you. Ashley wants to know if you can put in the intervention therapist completed collaborative documentation with the client. I wouldn't, because again, as it's part of the overall intervention, we're creating that summary. So again, I wouldn't necessarily do that, but you can, that you worked with the individual to document the important things we talked about today or gain an understanding. And again, Shana, this is with all individuals, and we do specifically break out in our individual trainings around working with children and adolescents and how best to approach that. So we have some breakout sessions that we work with child providers in documenting either in the home or in the office how to transition, because again, transitions are very important to children. So how do I transition either school-based or even office-based work or in-home-based work with that family child? We're transitioning from our work together to the note, and we talk about specific ways to do that. And I think one of the things to think about is that even if we do have trouble or questions about our typing skills, our words, that's fine. Do it in bullets. So let's start out with just typing in bullets in each of those sections. What goal did we work on? What is the response, progress, plan? What intervention did you provide? And I can always go back and clean up sentence structure and spelling. But also what's been interesting over the years is, I'm one of the world's worst spellers. And so just by being able to go in and misspell a word in front of an individual, a client is fine. That shows that we're vulnerable as well. So be prepared to be more transparent as a provider. So when the question came up is how would we sort of describe unkempt or delusional? I think you put in quotes. Michael believes that the FBI is monitoring all of his conversations through the radio. Use quotes. You don't have to say I'm delusional or paranoid. And then have that conversation, because if they are unkempt or they aren't taking care of themselves, grooming and hygiene, is that a symptom that needs to be addressed? And just having that conversation, building that rapport. Well, Michael, it looks like, when was the last time you had a shower? Do you have access to hygiene products? And maybe, you know, is just today the fact that I missed the bus and I had to walk 6 blocks in 90-degree weather, I might be a little unkempt today. So is it usual that I'm looking like this? Do I have access? Is it part of a symptom? Is it a strategy for me? So just having those conversations with me. So clinician discussed with Michael today a notice of increased body odor and how his clothes were dirty or had urine stains or smelled of urine. Michael reports that he has no access to soap or products or is currently unhoused and living in the streets. So would that prompt a care coordination opportunity or case management opportunity to help me get what I need? And remember, it's, you know, we're billing the entire session as part of the intervention. Okay. Other thoughts or questions, team, that you may have? Think about some of the key takeaways. We know that demand for outpatient and inpatient behavioral health care services are going to increase. The pandemic has exacerbated what we already are seeing in staffing and capacity needs. Collaborative documentation saves staff time. Collaborative documentation is an individual and family engagement tool. And collaborative documentation is a staff self-care tool. So if you're interested to learn more about the benefits of collaborative documentation and how we can be helpful for you and your organization, go to our website at mtmservices.org. And also feel free to contact me. My contact information is here, michael.flora@mtmservices.org, and we can talk with you about your specific program or organizational needs. And Sephora asks, what if the client disagrees with the description? There is no odor, then just document both. That you've observed an odor, the client denies or disagrees with it, and just document both. Remember, it's okay to agree to disagree with the individuals we serve. So I hope you found today's webinar helpful. If we can be of more help, please let us know. Thank you all and have a great afternoon.